today for this panel with a number of tremendous entrepreneurs working in the mental health and innovation space. But given the shooting that's just happened, I'd like to start with a moment of silence, and particularly because we're here in a healthcare conference and talking about mental health for the shooting that happened here in Nashville. So to get us started, on this important topic, we've got a number of startup health entrepreneurs that are doing some tremendous work, leading the way and innovating in this important space. So to kick us off, I'd like to have each person take about 3 or 4 minutes to talk about what your organization does, and then we'll dig into some themes. So Jade, maybe you could kick us off to get us warmed up this afternoon.
Sure, thank you for having me. I'm Jade Kearney. I'm the co-founder and CEO of She Matters. She Matters is a digital health platform designed to support Black women who experience postpartum comorbidities like postpartum mental illness. Additionally, we train healthcare providers on how to be culturally competent with our culturally competent certification.
That's wonderful. And maybe Raj, you could share a little bit about the work that you guys are doing at your company.
Great. So I'm Raj Amin. I'm CEO and co-founder of Arcade Therapeutics. We are making mobile games that act like medicine and are used to treat patients with mental health conditions earlier and more effectively. Big focus of the company is to really lower stigma and get to people in their own environments with an easier to use product than a lot of existing treatments out there, but also deliver those complementary to other treatments through providers.
Wonderful. Lauren?
Thanks for having me. Lauren Mills. I'm VP of Growth at Valera Health. Valera is a virtual mental health clinic. We treat everything across the spectrum of acuity in mental health, from mild depression and anxiety through serious mental illness like bipolar and schizophrenia, in a virtual model with a multidisciplinary approach to care, and anchored around quality and measurement-based care as well.
Great. Thank you so much. Last but not least, Anupam.
Yeah, first of all, glad to be here with some amazing panelists up here. We are a behavioral healthcare care coordination member engagement platform focused on seriously mental illness, who have complex care needs, who have lots of comorbidity. We have seen in our population, who we work with providers, 40% SUD comorbidity. And what we have done is, all this started from almost 6 years back. A very close person in my family who was going through a severe depression sadly ended his life. And there were so many trigger points we could have assembled at the right time, and that would have made a difference. And that's what we are trying to do. Trying to take a very full circle care approach of integrating both the clinical team, but also the personal support team. That includes your peers, your family members, and everybody else. And that creates a difference, so that they can bring the living experiences together, make sure they can build the trust onto that. We've worked with providers across the board, from community mental health. We started with the county system, community mental health centers, to treatment centers, to advocacy agency. But once again, we are patient-centric. We're trying to rebuild the behavioral healthcare state system by putting the patients at the center, not the providers.
Great. Thank you so much for that. So Lauren, I want to kick off with you. So you guys have developed a novel telebehavioral health model that's been gaining traction with payers and large health systems. What I'm really curious to hear from you about is equitable access, and how you guys think about the Medicaid populations or other populations that really we know need this care but sometimes aren't getting the access.
Absolutely, thank you. So by background, I'm a licensed clinical social worker, and I started as a clinician working with children in a Medicaid-funded program. I got involved in telehealth and virtual care around 2014, and what I started to notice was that telemental health models tended to be available for adults, the mild, moderate diagnoses like mild depression and anxiety, and typically was a pay out of pocket model or perhaps a commercial insurance model. What drew me to Valera is their mission to make virtual care accessible and more equitable to people that typically would not have access. So we work across commercial, Medicaid, and Medicare. We treat children and adolescents, and we treat those with serious mental illness. So these are all things that Valera is doing that are novel and different in the virtual space. And by partnering with Medicaid plans, we're able to reach members in both rural and urban areas, healthcare provider shortage areas, people who normally would not have access to this type of care.
Right. Thank you so much for sharing that. I mean, the accessibility issue is a huge one in the space you're working in. So Raj, I want to kind of turn gears a little bit into your innovation, because you're doing work that I think is quite interesting using gaming to address issues like social anxiety. So I would love for you to share with the audience some of what you've learned that's working, but also your view of digital therapeutics. So digital therapeutics is a growing space that I think there's a lot of traction in, but maybe people don't understand so well.
Yeah, sure. So, one of the big issues that we deal with a lot in mental health is just getting people started. Certainly, cultural sensitivity to mental health is a big challenge. So, part of what we think about is how do we lower that barrier and get to people in a low stigma way that they're comfortable with to get them started and to get some signal. Because a lot of the issues that we see are because we don't know who needs help. They're not being measured. We're not getting any signal from how they're doing, whether it's before a therapy session, whether they've had one or not. So we've got to find better ways to kind of get first-line treatments out that'll give us early data to help, triage and escalate where needed. So gaming as a modality is a great way to do that because it is the #1 type of downloaded application on mobile phones. There's a particular category called hyper-casual mobile games that are the really kind of simple games that you see people play everywhere, whether it's on a bank line or in the subway, and they're all accessible through mobile phones which have become increasingly powerful. So these games actually are super engaging and people use them. So what we've tried to do and what we've done in our recent games is really embed a cognitive training method inside of the game that is subconscious and can be used anywhere and can be used for a very short period of time to really kind of address one of the root causes of anxiety, which is something called threat bias.
Okay.
And so by doing that, our hope is really give these kinds of products to people on their mobile phones where they can use them. And hopefully, what we've proven in our most recent pilot study is we've actually been able to affect 68% of patients that were using the product and move them down in clinically meaningful levels of anxiety. And actually, 38% of those patients came out of 30 days of use with subclinical levels of anxiety. So, that's huge impact for patients, and it's done in a very low stigma way. So the good news in that is that we had 95% compliance as well, which is really impressive in the world of kind of digital therapy. So goal is get to people early, get them treatment. If we can't treat them only with this type of a treatment, then we can at least escalate them into the rest of the care system.
Right. That's really interesting. Kind of shifting gears, like Anupam, with your model, really you guys put the patient in the center and also are focused on cultural awareness and cultural competency and how we close gaps in care. So maybe you can tell us a little bit more about your model and how you're closing those gaps in care for vulnerable populations, and maybe an example of something you've seen work or a case study.
No, I think I would love to. So cultural relevancy is such a big topic, which cannot be covered in 2-3 minutes or even a day as such.
Right.
If you look at cultural relevancy in the healthcare system, you're trying to make sure the diverse value, beliefs, and behaviors are included. The socio, cultural, and linguistic, right, needs are being managed. So of course we do it, make sure that the language barriers are broken. So we have all the translation, real-time translations inbuilt to it, because their families are involved, peer supports are involved, various different experiences perspective. The second thing comes from our providers whom we work with, right? Community mental health centers, treatment centers, health systems and all, is on the provider skill side, like what Steve was talking about, is all about making sure that they not only they have knowledge and skills, but do they have the specific ways to deliver that as they create the care plan? So what we do is, if some shortcomings are there, we send them trigger messages with the help of providing those feedback back to the thing. And then the third thing, which is very, very important, is where you are in a clinical setting and integrating that clinical workflows to 150 plus, is what happens if the people are not even taking a care, like what he was talking about, Raj, and what happens between the encounters as well.
Right.
That's where the care team can be very, very powerful if it's well integrated into the system. And that's where the community support is on the ground. So that's where we have seen like 78% reduction in rehospitalizations, working with people from psychiatric hospital to 36% reduction in ED visits. But that's the goal, right?
Okay. Great. No, that's a really good framing and example. And Jade, I want to build on that with the work that you're doing with She Matters. And
Yes.
I think that, one, we've been hearing so much in the U.S. about the Black maternal mortality crisis in our country.
Yes.
And so I'm curious, one, about kind of your personal journey around this and how you see health equity and kind of some of the opportunities and challenges based on the work that you're doing.
Well, thank you. And Black maternal morbidity is a huge crisis, as we all know right now. My personal story is that after I had my first daughter, who's 5 now, due to cultural stigma, when I felt like something was wrong, I didn't know what was happening. I went to family and friends, and I was told Black women don't have time for postpartum depression. I was actually told I needed to go back to work for my health insurance. And, you know, there's a huge cultural stigma in the Black community around any type of mental health care. So I knew I wasn't going to get help there, but where I was so hurt was that I didn't get any help from the healthcare system either.
Right.
And I was immediately given an antidepressant and sent away. I knew right then and there that cultural competency was so important for healthcare providers, and that's why we have our culturally competent certification. Because I had health insurance,
Right.
I'm educated, yet I couldn't find any help. And at She Matters right now, we have over 2,000 Black moms. 73% of them have health insurance, and they're waiting for culturally competent care. They're waiting for us to have more therapists and more doctors who are culturally competent and certified by us for trust.
Right.
And that's what health equity really is. It's trust. And if
Trust, yeah.
you look at the challenges and the nuances that Black women have experienced in the healthcare system in the United States, everything starts with communication and trust. And that's why I think our certification is extremely important. Because if you don't start there, where do you go?
Right.
How do you communicate with people that are different? How do you meet people with empathy and serve them if you haven't taken the time to figure out who they are?
That is so well said, and I think also a point you've made that I don't want to lose is that this isn't an issue of just low-income populations. This is an issue across the board, right? The studies have shown that even for Black women who are high income, they're still 2 times more likely to die giving birth than a poor white woman. So this is beyond just socioeconomic issues. It's a much bigger issue. I love how you frame that, and thank you for sharing your story. Lauren, back to you. I want to pick up on this thread, kind of talking about equitable access, but also talking a little more about social determinants of health, right? When we think about behavioral health, and in your case, you're using technology to make it more accessible. There are also a number of different barriers that one might face growing an organization like yours and thinking about those broader social determinants. So how do you guys see that in your work, and how do you go about addressing those type of issues?
Yeah, absolutely. We do see it very often, and one of the things we do to address it is a team-based approach to care. So in addition to the licensed therapists and MDs and nurse practitioners that we have on our team, we have case managers and care managers who help to reach out and engage folks, meet them where they are to engage in care. If they had a no-show for any reason, they'll follow up and say, are you okay? Can we reschedule? When is it convenient for you? Really making it as, friendly and convenient as possible for people to continue to engage in their care. And we are able to screen people for social determinants, and the case managers can help connect them to community resources that they might need in addition to the mental health treatment. And the other piece of that is partnering with health and hospital systems as well as primary care and specialty groups so that we can tie in the behavioral health with the physical health and have a whole person approach to care.
Right. Thanks so much for that. Yeah, I think the way you're approaching it, I think, is some of the challenge for entrepreneurs, because you have to do more than just the technology, right? The technology is part of it, but you've described some of these other elements, and we're hearing that from other groups. But Raj, for you, with your organization, when you think about digital therapeutics, and maybe not everyone here is familiar with what that is or how it works, but maybe you could describe what digital therapeutics are as a space, and what you see as some of the opportunities to help move that sector forward.
Yeah, it's a big question.
We have some time.
I'll give it a shot. Give it a shot. So digital therapeutics, have been talked about for years. I think the thing that's changed in the past couple of years has been a focus on prescription digital therapeutics. So, really kind of moving from, I think, products that have some clinical base to products that have been clinically tested in a very rigorous way. And usually what that means is some type of an FDA pathway, or in our case in the US. And so what that does is it really gives a lot more credibility to these products, because I think what we've found is that the critical approach that works the best in getting these products into patients' hands and supported by the healthcare delivery system is by having the credibility of an FDA clearance, so that physicians can really rely that these products have been tested in a rigorous way. And so those are typically RCTs, placebo-controlled trials that are done. And so we actually, kind of our journey as a company, my co-founder at the company is a chief science officer. She developed this original technology called attention bias modification, and created it in a lab. And we tested it in the real world for many years, and did clinical trials around it. But now, with these new pathways like a 510(k) clearance, we can shift to an FDA clearance strategy. And so our new prescription product, which we announced about a little over a week ago, we announced our FDA pilot results, is going through that pathway. And so digital therapeutics that are getting cleared in this type of way can then be prescribed and can be reimbursed on formularies, just like medicines are. In addition, you also have codes that are used for physicians, so that we can pay for the time that it takes for physicians now who are going to be part of this delivery mechanism to onboard patients onto these products, and to look at the data that's generated from the products. So all of that is kind of the ecosystem of, I think, moving from a lot of software products that make claims to fewer software products that are going through the level of research required to really be deployed through the provider ecosystem.
Thank you so much for sharing that. I want to ask another question building off of that to you about algorithmic bias. So a lot of these solutions, when we think about equity, there's a conversation about how we ensure that these solutions aren't creating any unintended harm. And we understand algorithmic bias and other things are issues that are getting discussed a lot today, and how we think about that, how we address that from a regulatory perspective. So just given what you said, I'm also curious what your thoughts are on that, or how you see it.
Yeah, I mean, I think, trial participant recruitment is a big part of it, making sure that you have, as you're recruiting for the trial, we've tried to be very sensitive to that in terms of how we're representing a national sample size and all the makeup of that sample. So I know that our, and this is Tracy's area of expertise in terms of the clinical trial recruitment, but we think about it every day, especially in the fact that, our whole purpose for being is to lower barriers for everyone, and to be much more culturally sensitive as to how these products fit into people's lives and different circumstances.
Right. Thanks for that. I gave you some big ones. Thanks for that.
No.
That's helpful, and I think you've laid it out in a way that I think is easy for people to understand. Jade, kind of building on this theme of just equitable innovation, and really, you've talked about your lived experience and how that really shaped your offering, because you were someone yourself who was going through the things that you weren't seeing were being offered. What might you advise folks here who are really trying to be intentional in their offerings and and that really want to try to make them accessible to the broadest array of folks possible with these different lived experiences. Like, how do you approach that, and what advice can you give to other solution providers?
I think you have to be genuine in your want to have to help a diverse group of people. I think it's like buzzwords right now
right.
to say, like, we're looking for equitable care, we want equitable care, we want to offer that. But you know the people who are doing the groundwork. They're making strides, but they're already also putting their money where their mouth is and investing in equity. They're investing in health innovation, and they're doing that through many companies, not just ours, but investing in a culturally competent certification, investing in community workers, investing in people that look like the people that you're trying to help. I hear it a lot when people say, we can't reach these people. People come to She Matters and say, we really want to reach these populations, but what are you doing to reach the folks? It is not Black women's job to reach out to therapists. It's not Black women's job to reach out to the physicians. You really have to take an interest in what you're doing and really care. And that means putting the money there. That means putting the people there, but it also means getting the community involved.
For sure. Thank you for that. No, that's completely dialed in. And tell us more about kind of some of the milestones that you're achieving with your organization, and some of the types of partners or support could help you grow your work.
Well, some of the milestones, we have over 10,000 Black women that are a part of our user network, which I'm very excited about. We've most recently added doulas to all of the healthcare providers that we offer to our Black moms. We're not only focused on large health enterprise like hospitals, we're focused on smaller medical centers and community centers as well, because we believe that it's not just a large hospital network that will get to the people, but like small clinics that also help community populations as well.
Right.
Yeah.
Thanks for that. No, that's amazing. Anupam, over to you. Maybe you can explain to the audience how your offering works. So I think you've laid out some really good principles, and it's clear you have an intentionality around closing gaps in care, but how does the solution work? Like, what exactly is it, and how are you getting the results that you're getting?
Yeah, a great question. So I think the biggest thing is for us is how do we look at the team-based care model, as I was talking about. So if somebody leaves a clinic or a health system or a community mental health center or advocacy agencies or anything else, the first thing what our platform does is trying to do a screening, right? But this is not just based on the PHQ-9 or GAD-7. We're trying to look at the cultural part of it as well, right? Trying to understand what are the different contributors for it. That dictates to an AI-based system which divides and gives them intelligence around the care team, what the care team should compose of it. So for a person, if you're working in a school system, of the players would be quite different as compared to if you're working with a university or working with somebody else. And the diagnosis needs of that individual and from where they're coming. Then care team is also given tools and the process flows to how to engage effectively with these individuals. So not only that, okay, the care team is there so they can communicate, have a shared care plan, and they can track and monitor progress and proactively intervene, but also about exactly how to share that data and all that. All that data goes back, and then the care coordination comes into picture where we coordinate with different providers and the needs of it in a very holistic manner, like she was talking about. So not only from a community provider. So we work with like advocacy agencies like NAMI and various other things like across the board, so we can take it very holistically. And then we take that.
Great.
Sorry.
Jade, yeah.
I just wanted to add this because it's one of my favorite things that we're doing. We've taken the Edinburgh scale and made it culturally competent. So I wanted to add that we have a culturally competent maternal health scale that I'm very proud of, that we're working on right now. And I think it's gonna be really big because everyone knows the Edinburgh scale is not culturally competent.
Right.
It doesn't take language. It doesn't take ethnicity. It doesn't
everyone
take
is
race.
trained on.
Right. Right. And so many moms do not tell the truth because they don't understand the scale.
Right.
So that's something we're actively working on as well.
That's amazing. I'm seeing lots of synergies too in this group, so that's incredible. So I think Jade actually kind of teed something up for me that's been on my mind, which is, and I want to ask each of you as we think about mental health or behavioral health space and innovation, what's one thing that you think, if unblocked, could be a huge enabler for the space? So Raj, I'm going to start with you.
Well, I mean, I think a lot of times where mental health issues really surface, it may not be a doctor.
Right.
You know? We need to think about what those first touch points are and how do we enable those people to be part of the broader healthcare system. So, you know, for digital therapeutics, I mean, one of the issues I struggle with is, you know, we love to provide these products into schools, into universities, but the current prescribing behavior of digital therapeutics is it's got to come through a provider, which is fine, and I think that's important. But there's also a lot of other touch points out there where these mental health issues are being surfaced. And so I think the connectivity between those who are on the front lines or enabling some of those people on the front lines to become prescribers of certain types of digital therapeutics or other services, or at least connect that patient into the rest of the ecosystem is going to be really important. And I don't think that those connections exist at the level they need to.
Today. Lauren, what do you think?
Yeah, I think there are some regulatory and policy issues that could be unlocked to make a huge difference. As a provider group that does work with Medicaid, it's operationally very challenging sometimes to get the state approvals that we need, the credentialing done that we need. It can take 12 months sometimes in a new state to get qualified licensed providers just up and running in the system to see patients. And similarly with cross-licensing, there's a shortage right now of mental health providers. If we were able to more easily cross-license our licensed clinical social workers across states with a state compact, for example, we could really maximize their efficiency and see more patients. So there's things on the policy side that I think would make a huge difference.
Great, thanks for that. Jade, what do you think?
I don't think I can't think of what should be unblocked, but I know what should be added.
Okay,
and that's
great.
cultural competencies should be a requirement for physicians. You should not be able to graduate from medical school with an hour of diversity and inclusion. If there were requirements around cultural competency, I think a lot of those systemic problems that we have around racism and health equity would change, because people would be equipped to serve populations that are underserved, and people are not because they never interact with them.
Yeah, no, I think that's valid, and I heard a stat from the American Medical Association that just perplexed me, and it's a recent stat from last year that said 2/3 of white medical students today think that black people have a higher pain threshold than white people. That's 2/3 of white medical students today, right? So this is what Jay's getting at. Like if even in the mindset of our newly trained physicians, that's how they're thinking, that's the bias that's there, then, I mean, to Jade's point, like how do we unblock this? Yeah.
And there was a study done out of Colombia where 2 women, one black, one white, both had the same symptoms, all of the same problems, and the black woman was given 2 Tylenols, and the white woman was given a Percocet. These are the things that happen, and those are all due to cultural biases that could be changed with education.
100%.
Yeah.
Anupam, over to you.
Yeah, I think amazing points have already been covered. The one thing which I will add to it is always look at whom are you developing stuff for. So by that I mean, if you're developing it for patient, understand the patient population really well. Technology has to go hand in hand with our care delivery models, because sometimes we overlook that and we deliver great tools, but then we don't see great engagement. So I think it's very, very critical that how you're delivering it, what they accepted, cultural nuances to be kept into equity of that. Otherwise, you will not be able to get the right level of outcomes, which we truly deserve. They need to live that same level of life, and I think that's extremely critical.
Thank you so much. You guys have really dropped a lot of gems on this one, so I appreciate all of your insights. We're just running out of time, so I want to do something briefly. For the audience, just for each of you, if you could share any type of partnerships or things that you're looking for as you're here at the conference. So I'm just going to go down the line here. So Lauren, starting with you.
Sure. We love to partner with other groups that have synergy with us that are looking for a behavioral health component. So oftentimes there's an overlap with things like chronic pain, with perinatal mental health, for example, other kind of specialty and primary care groups looking to refer to behavioral health and have a true collaboration where we can really look at quality and outcomes and working together to get the best possible care for patients.
Great, thanks. Yeah, just briefly what you're thinking, Raj?
Yeah, I mean, we're releasing our prescription product next month, and so we're moving into clinical pilot programs so we can test the product in real-world scenarios integrated with providers. So we're looking for those types of partnerships.
Great, thank you so much. Jade?
Hospital networks, academic hospitals, clinics, therapists. That's what we're looking for.
Wonderful.
Yeah,
Last but
I
not
think
least.
from our community mental health centers and health systems and all to partner with it and make it available to more masses.
Wonderful, thanks. Let's give this panel a hand. You guys did great. Thank you.
Thanks a lot.
Now we're just